Could you see my PPT?
Yeah, yes, we can see it, sir.
Okay, thank you. Good evening, dear Chairman Professor Yang and Professor Madoff, Professor Goldberg, Professor Softclears, and Professor New. It's my great honor to be here to share the topic of colorectal cancer liver metastasis ablation. With so many experts online, the topic I'm going to talk about today is MDT-based ablation strategy of colorectal cancer liver mets. So first, let's look at the case. A 57-year-old female patient complained of abdominal pain and the mucus blood stool for 1 month. Colonoscopy revealed sigmoid colon cancer. There was no distant metastasis at baseline. The patient underwent radical resection of sigmoid colon cancer. The post-operative pathological stage was T1N1M0, and the genetic test was KRAS mutation. She only received 3 courses of FOLFOX chemotherapy after surgery due to blood bleeding. On August 2018, PET-CT showed multiple metastases in bilateral NAN and isonate liver metastasis. Then she received 6 courses CPT, 11 plus Avastin chemotherapy, and 3 courses maintenance chemo with Xeloda plus Avastin. So this is imagined comparison before and after the maintenance chemotherapy. The evaluation of the efficacy of metastasis in both nests is stable, but the isonate liver lesion in the second segment have progressed significantly. So we can see it became to 3.9 centimeter after 3 courses maintenance chemotherapy. So as for the current situation of this patient, we need to face 4 problems in the follow-up treatment strategy. The patient is in a non-NED state. Does the liver lesion need to be treated? What kind of treatment is used for isolated liver lesion? Surgery or ablation? It is an indication for ablation more than 3 centimeter. If ablation is taken, radiofrequency or microwave ablation. So before answering these 4 questions, we need to clarify 2 concepts. One is Oligometastasis Disease, OMD. This concept was first proposed by 2 professors at the University of Chicago. Oligometastasis, OMD, refers to an intermediate state in the process of tumor metastasis. It's a relatively mild, biologically aggressive stage between localized primary tumors and extensive metastasis. In this stage, primary tumor cause only a few localized or of secondary tumors. Usually, the number of metastases is less than or equal to 5, and the number of organs involved is less than or equal to 2. It is representing a potentially curable stage. The key treatment is local treatments such as surgery, thermoablation, and radiotherapy. At the same time, systemic chemotherapy is used to prevent further distant metastasis. At the ASCO annual meeting last year, some updates were made to the concept of oligometastasis, and OMD with no tumor burden were proposed. OMD with no TB means up to 3 involved organs, up to 5 metastases, up to 3 metastases per organ. Maximum size of metastasis less than 3 centimeter, absence of ascites and peritoneal bone central nervous system metastasis. So from these 2 figures, we can see that there are a significant difference between OMD-based no-TB and non-OMD-based no-TB on PFS and OS. It is verified once again that OMD can bring survival benefits through active local treatments to achieve NED. Another conceptual change in the field of CRCLM is to shift from radical surgical resection to NED as the core. This conceptual change provides a wide range of local treatment methods, including ablation and radiotherapy. So at the ESMO 2016 annual meeting, a local treatment toolbox was proposed for liver metastasis from CRC. In this toolbox, it is divided into local treatment and local regional treatment. So local treatment is mainly for OMD to achieve NED, and the local regional treatment is more as palliative treatment. In addition, according to the NCC guidelines of the 2020 V4 edition, palliative ablation is not recommended. It is required that all lesions can achieve curative damage before ablation treatment is considered. So in the 2015 consensus on CRCLM formulated by global experts, the best indication for ablation is less than or equal to 3 centimeters, and the number of lesions is less than or equal to 3. So we go back to the case just now. After discussion with MDT, it is believed that the biggest threat to the patient's survival is still the rapid progress of liver metastasis, which can be treated on the basis of maintenance chemotherapy. For the liver lesions, a double needle microwave ablation technique was used to achieve complete destruction. So why do we choose microwave ablation? Here we discuss radiofrequency ablation and microwave ablation. Both of them use electromagnetic resonance to generate heat to destroy the tumor. The radiofrequency only hits the tissue in the range of 3 to 5 millimeters around the electrode, and the ablation range depends on the heat diffusion around the electrode. The tumor tissue heated by microwave is wider, which has the advantage of resisting the heat sink effect caused by blood flow. So is microwave better than radio frequency? An article published by MSKCC in 2016 suggested that microwave can improve local control and significantly reduce local recurrence rate than radio frequency ablation. Another question is the rapid heating of microwave more dangerous than RFA for CRLM? An article published on CVIR thinks for perivascular CRM, RFA and MWA are both safe treatment options that appear equal effective. For peribiliary CRLM, microwave ablation has a higher complication rate than RFA with similar efficacy. So based on these results, it is advised to use RFA for lesions in the proximity of major bile ducts. Compared to radio frequency, the advantages of microwave ablation also include faster heating and higher temperature within the targeted area, large area of active heating, more uniform heating area, and lack of heat sink effect. Efficacy not impaired by tissue desiccation and charring, and no grounding path necessary. How do we choose in clinic? Let's compare them through a scoring system. Scoring items include effectiveness, safety, convenience, probe, ablation time, large tumor, price, and experience. Microwave ablation is generally better than radio frequency due to 7 score. In addition to OMD, what other scenarios for ablation except OMD? So based on our hospital's MDT experience, we summarize as follows. Non-OMD but less than 9 lesions. Extensive metastasis more than 10. Imagine evaluation as OMD after chemotherapy. Number 3, non-OMD status but individual lesion progression during maintenance chemotherapy. And the last one, before the start of new neo-adjuvant or conventional chemotherapy, it is assessed as a small lesion that easily disappears after chemotherapy. So for the number 1, non-OMD less than 9 lesions. JNCI published an article that compared with chemotherapy alone. Chemotherapy combined with radiofrequency can improve the overall survival of patients by 4.7 months. So number 2, extensive metastasis more than 10 lesions. Imagine evaluation verified as OMD after chemotherapy. So for example, this 43 years male patient, chief complaint is physical examination revealed multiple liver nodules 2 weeks ago. MRI considers liver metastasis, right adrenal gland metastasis. Colonoscopy showed sigmoid colon cancer with multiple colon polyps. So baseline examination revealed a total of 17 lesions in the liver and the right adrenal gland, which were initially unresectable and non-NED. But after 10 cycles of chemotherapy, FOLFOX plus C225, only 3 liver lesions and right adrenal gland metastasis can be shown in MRI images. After MDT discussion, 2 lesions in the liver were treated with ablation, and the metastatic tumor near the inferior vena cava and the right adrenal gland lesion were treated with SBRT. Then the RODA maintenance chemotherapy go on. The patient has been in NED state till now. So we can see all the lesions completing necrosis in CT contrast scan. Some patients with multiple liver metastases require new. The number 3, non-OMD status, but individual lesion progression during maintenance chemotherapy just to be discussed at the first. So we passed this case. Number 4, the easily disappears after neo-adjuvant chemotherapy. Some patients with multiple liver metastases require neo-adjuvant chemotherapy or conversion chemotherapy before surgery. For lesions that easily disappear after chemotherapy, ablation can be performed before chemotherapy. This patient now, let's see this patient images, has 2 lesions in the liver, and the small lesion easily disappears after chemotherapy. So ablation is performed first. Okay, the next patient is also the same, faced the same situation. The small lesion will disappear after chemotherapy. So the small lesion was treated with ablation first. Why do we worry about the lesion disappeared after chemotherapy and adopt early ablation treatment? This kind of imagined disappears is called clinical complete remission in CCR, not true pathological complete remission. Once the imaging disappears, it will bring difficult to subsequent surgical treatment, especially laparoscopic surgery. If disappeared lesions are not treated, the cumulative risk of recurrence of up to 40 to 50%. So some people will say that surgery cannot find that we can simulate ablation through anatomy, but this strategy, expert group also does not recommend it. Small lesions that can be seen on MRI, if possible, can be performed, and the MRI guidance. Okay, these are what I want to share with you today. Finally, make a brief introduction. The renewal of the concept of the treatment of liver metastasis from colorectal cancer highlights the importance of local destructive treatment. The indications for ablation treatment of liver metastasis from CRC should be grasped, and individualized treatment strategies beyond the indications should be formulated through MDT for the discussion. So thank you all. Thank you for your attention.